Well, good morning, everybody. My name is Christoph Stremikis, and I'm the Director of the Market Analysis and Insight Program at the California Healthcare Foundation. CHCF is an independent, nonprofit philanthropy dedicated to meaningful, measurable improvement in the healthcare delivery system here in California. Today is an exciting day as we highlight another study from our Regional Market Report series. You'll see on a slide that'll pop up on your screen here that our regional market reports are in-depth studies of 7 diverse areas that reflect the range of socioeconomic, care delivery, and financing conditions that we have here in California. You can find this report, which is focused on the Sacramento area, and all the collateral from this webinar on our website at chcf.org. We'll continue to release regional market reports and conduct webinars like this through the next month or so. On the next slide, you'll see that we're fortunate today to have the lead author of the Sacramento report, Len Finocchio, here to briefly highlight his findings. And we're also joined by the impressive group of local healthcare leaders that you see on your screen. Each is here to talk about the unique challenges and opportunities that they're seeing in the Sacramento area from their perspective. 2 very brief housekeeping items before I turn things over to Len. First, please do take advantage of our panel's expertise by entering your questions into the Q&A box at any time during the next hour. My colleague and Senior Communications Officer Lisa Alaferis will monitor these questions, and we'll squeeze in just as many as we can after everyone has had a chance to speak. Second, please do take a minute when the webinar concludes to fill out the evaluation that's going to pop up on your screen. Your feedback is really valuable, and I can assure you it'll help inform our future programming. So with that, I do want to get started and turn things over to Len. Len Finocchio is principal at Blue Sky Consulting Group and lead author of the Regional Market Report on the Sacramento area. Len, I see you've got your camera on and yourself unmuted. Can you get things kicked off for us?
Thanks, Christoph. Good afternoon, everyone. Thanks for being here and welcome. We'll spend the next 15 minutes or so talking about our study of the Sacramento area, which we, after spending a year of interviews and looking at data, we titled this report, Large Health Systems Grow in a Pricey and Tumultuous Market. So how did we undertake this? So we wanted to tell the story of the healthcare landscape and developments over the past 5 years. We did interviews with 24 regional leaders representing health plans, healthcare providers such as hospitals and health systems, federally qualified health centers, county government officials, community leaders, and also advocates. On the quantitative side of our work, we looked at data from the California Health Interview Survey. We used data from the US Census and other sources. We reviewed industry reports, journal articles, and also news stories, particularly from the Sacramento Bee and the Sacramento Business Journal. Just a little bit of context. Of course, we've been in this pandemic for a year. We added questions last March that addressed COVID-19 and asked them of our interviewees. It wasn't our intention. The COVID-19 did not become a principal focus of the study. We remained focused on the market at large, but we do have a section in the report, and we'll talk about it today about COVID-19 and the impact. We conducted interviews from January through October of 2020. And I'd like to acknowledge my co-author, James Paci from the Blue Sky Consulting Group. A little bit of background on the area. So the Sacramento area is not just Sacramento County alone, but it comprises 4 counties, Sacramento, El Dorado and Placer, and Yolo County. It's a very diverse region. It includes a very urban area, lots of suburbs, of course, farmland, and also the Sierra foothills all the way to the Nevada border. When looking at this region compared to California overall, the population is a little bit better off financially. It's a little bit younger and also a little bit older compared to California. It's less diverse. So there are fewer Latinx residents than compared to California broadly, and it's more white. The population has been growing faster than California broadly, and it's generally a healthier region. So if you look at the pie chart, you'll see that Sacramento is about 52% white, whereas statewide, the state is 37% white. The Latinx residents in the Sacramento area comprise about 22% of the population, whereas in California, it's nearly 40%. And Lastly, the African American population in Sacramento region is about 7%, and statewide it's 5.6%. For health insurance coverage compared to California, the residents in this 4-county Sacramento region have more private coverage, less Medi-Cal. There are fewer uninsured residents in the region, and on average pay higher premiums for covered California plans, than statewide. And that difference is about 17% higher in the Sacramento region than premiums are statewide. And so again, if you turn your attention to the pie charts, you'll see in the Sacramento region, about 51% of residents have coverage through their employers, private coverage. About 25.5% have Medi-Cal, compared to almost 29% have Medi-Cal statewide. There are more people on Medicare in the Sacramento region, 17.8% compared to about 16% statewide. And for the uninsured, the Sacramento area has 5.3% of its residents are uninsured, whereas in California more broadly, 7.7% of people are uninsured. We looked at the Medi-Cal managed care model. There are actually 3 models of Medi-Cal managed care in this region. There's the county organized health system, which is Yolo County, and Medi-Cal members are served by Partnership Health Plan in Yolo County. In El Dorado and Placer County, that's the regional model where there are 2 plans which compete for Medi-Cal lives. Those plans are Anthem Blue Cross and California Health and Wellness. And in Sacramento County specifically, there's the geographic managed care model, or GMC, which we found to be rather crowded and chaotic. And I'll explain why in a moment. So you can see in Table 3, there are 5 plans that provide care to Medi-Cal managed care enrollees. So there's Anthem, HealthNet, Kaiser, Molina, and Aetna, with Anthem Blue Cross having 41% of all Medi-Cal managed care lives, and then the other plans having the remainder. In 2017, the Department of Healthcare Services added 2 plans to Sacramento GMC, which had 4 at that time. The 2 plans were United Community Health Plan and Aetna, which began providing services in 2017. And then toward the end of 2018, United Community Health Plan left the market. And as a result, there were about 8,000 Medi-Cal enrollees who had to transfer to another of the remaining 5 plans and also find new providers. So it may get more chaotic over the next few years. The Department of Healthcare Services plans to recontract with plans serving Sacramento GMC with a request for proposal, which will be released this year sometime. They've also signaled that they intend to reduce the number of plans participating in GMC in Sacramento. So rather than 5, it would be reduced to some other number. We don't exactly know how many. In addition, the Sacramento County Board of Supervisors at the very end of 2020 is creating a health authority with the power to adopt a 2-plan Medi-Cal managed care model and designate how many GMC plans can participate in the Sacramento region. So more changes are coming in the next few years for the geographic managed care model in Sacramento. We looked at the hospital and health systems and physician markets. And here I note that hospitals and physicians have continued to consolidate, and the hospital systems generally have healthy operating margins. The hospital market experienced increased consolidation between hospitals and medical groups. So by 2019, 70% of primary care physicians and 80% of specialists belong to practices controlled by a hospital or health system, which is a higher percentage than most compared to the other regions that we studied. There have been increases in health systems operating margins have generally coincided with this consolidation. And we also cited in our paper a RAND study that was done last year, which found that hospital outpatient and inpatient rates paid by commercial and self-insured plans are higher in the Sacramento region than statewide. And if you look at table 9, right, you can see in 2018, the operating margins of all the major hospitals and health systems in the region. And in all Sacramento hospitals, on average, have a 10.5% operating margin. And if you compare that to the statewide average is only 4.4%. So hospitals, except for Marshall Medical Center in El Dorado County, have healthy operating margins. Federally qualified health centers over the past few years have taken on a much larger role in serving Medi-Cal members and, of course, the uninsured. They've expanded the number of sites and also increased the number of patients per capita that they serve. So again, pointing you toward the table 10 on the right, the patients per capita served by FQHCs has increased 56% since 2014, largely due to the Medi-Cal expansion from the Affordable Care Act. Encounters per capita have also expanded by 55%. And you'll note here that operating margins have decreased since 2014, and that's largely due to high capital expenditures during their expansions and adding new sites and workforce. So FQHCs have increasingly served as primary care homes for Medi-Cal enrollees, as many small medical practices have closed and large medical groups have shifted patients to FQHCs, shifted their Medi-Cal patients to FQHCs. FQs have also expanded the services that they provide over the past few years to include mental health and substance use disorder services. In fact, some FQHCs provide specialty mental health services with contracts to the counties. Yet many struggle to recruit and retain staff, particularly behavioral health professionals. We heard a lot about licensed clinical social workers, marriage and family therapists, and also psychiatrists being difficult to retain and recruit, and also particularly child psychiatrists. Also examined the behavioral health system for Medi-Cal enrollees specifically, not the broader private market, but really focused on Medi-Cal enrollees. And it's a very complex behavioral health system, which has made strides over the past few years amid capacity challenges. And you'll see in the table, we lay out what's called the penetration rate of Medi-Cal enrollees using specialty mental health services. And so this is the percent of all Medi-Cal enrollees who have had at least one specialty mental health service delivered by the county. And statewide in 2018, as you will see, about 4.7% of Medi-Cal enrollees have had a specialty mental health service. And in the Sacramento area of the 4 counties, on average is 3.7%. And you can see we laid out the other counties and their penetration rates. So county mental health plans have wrestled with capacity issues, but have made improvements, such as collaborating with criminal justice agencies and Medi-Cal managed care plans. The Drug Medi-Cal organized delivery system has expanded service options for substance use disorders. And there have been other capacity challenges, which include, again, like FQHCs, difficulty finding and retaining behavioral health providers, and also inpatient psychiatric bed limitations. The behavioral health system has also been working to address the needs of the homeless, and this has required multi-agency collaboration and often multi-county collaboration. And as I mentioned earlier, the Sacramento geographic managed care model with 5 plans and many provider networks and formularies can make navigating the system for a Medi-Cal enrollee very challenging if he or she has to move between Medi-Cal managed care plan and the county mental health services. We also examined health information exchange and discovered that it's quite siloed and rather limited in this region. So health systems typically exchange data internally through their EHRs, with limited data sharing outside of their systems and with other providers. There's some data sharing with FQHCs and some data sharing with health plans, but as I mentioned, it's quite limited. And when we asked why, health systems noted and clinics noted that they're not prioritizing broader data exchange given all of the other demands on their time, on their resources, and on their leadership. Participation in Sac Valley MedShare, which is a regional health information organization, or RIO, has been slow among metropolitan Sacramento providers. Sac Valley MedShare is generally kind of north and east of Sacramento. And lastly, accessing behavioral health data is very challenging due to privacy restrictions and also connectivity issues, but there are some efforts underway to improve the exchange of data between a county and other providers. And for COVID-19, excuse me, we looked at data to understand the impact of COVID-19 in the region. So we looked at the unemployment rate and Medi-Cal enrollment. And as you'll see, unemployment rate almost doubled, but that increase was not as large as the increase in the unemployment rate statewide. Medi-Cal enrollment has increased modestly, at least as far up to October of 2020. It increased by 4.3% in the Sacramento area, whereas statewide it had only increased by 1%, and that was as of October. It has increased more since then. And of course, COVID-19's impact on providers has been significant and wide-ranging. Early on, of course, there had been many struggles to get enough personal protective equipment, workforce shortages, and other demands. The CARES Act funding has certainly helped, and you'll see at the bottom of the table to the right that Sacramento area providers have received $227 per capita of provider relief funds, which is more than the $150 per capita on average statewide. From a financial perspective, we discovered that providers receiving capitated payments have fared much better than those relying on fee-for-service payments. So capitated payments are amounts that each provider receives per member that they serve per month, rather than relying on a fee-for-service payment, which is every time you provide a service, you get paid. With a capitated payment, you have a monthly sum to rely upon. Oops, excuse me. And lastly, there's been a tremendous growth of telehealth among most providers who have had to pivot away from in-person visits and use audio or video calls with their patients to deliver services. And lastly, at the end of each of these market reports, the authors kind of look forward into the future and lay out what the issues should be that should be tracked and to see how the market evolves. And so we felt that these would be the issues to track. So will Sacramento County's GMC model evolve in ways that ease provider burdens and simplify and improve access to quality services for Medi-Cal enrollees? Will the remaining independent physicians and two smaller independent hospitals join the region's large health systems? What countervailing forces will remain to keep health system payment rate increases in check? And what are the next organizational developments for federally qualified health centers as they assume more responsibility for Medi-Cal enrollees? And what imperatives will drive improved health information exchange and participation in the Regional Health Information Organization? And lastly, how will pilots and other innovations in behavioral health improve access for Medi-Cal enrollees? And can any improvements be institutionalized through the California Advancing, Innovating Medi-Cal, or CalAIM initiative that DHCS is pursuing? And so I will hand it back to Christoph to lead us in a panel discussion.
Well, thank you so much, Len. That's really a nice job summarizing a very wide-ranging report. Thanks for providing that general overview. And you're right, at this time, I'm really excited to turn things over to a panel of local healthcare leaders for their perspective on the challenges and opportunities that they're seeing in their communities. Just as a reminder, each panelist will provide about 5 minutes of remarks on any findings that were particularly surprising, anything that really resonated, or anything else they'd like to highlight. And as a reminder to our audience, please feel free to type questions for our panelists into the Q&A box. We've already got several good ones in there already. Please keep them coming. So at this time, I'd like to turn things over to our first panelist, Ann Boynton. Ann is Executive Director for Strategic Planning at UC Davis Medical Center. And I see you have your camera on. You've got your mic unmuted. How do things look in the Sacramento region from your perspective?
Good afternoon, everyone. And first, I'd like to thank CHCF for contributing to this important work. The insights from this work are always valuable and provide balanced perspectives on each region's market situation. They're a wonderful resource for educating people about the incredible variety of healthcare landscape in California. So thank you for the work you do around this. I'd like to start off just by pointing out that all of us in the healthcare world, particularly in the hospital side of things, are intensely cost sensitive and understand the extreme cost pressures that healthcare places on everyone. We are aggressively seeking out ways to move care out of the hospital to lower cost settings, reducing length of stay, treating and monitoring at home, and working with community organizations. And all of this work will continue. Integration is really a critical aspect to successful value-based payment and long-term cost reduction, cost containment. Sharing risk, for example, between a health plan, hospital, and physicians requires significant investment of time and resources, including financial, personnel, data management, and ongoing governance structures. So we can't enter into these arrangements without extensive integration between the involved parties because it creates too much risk otherwise. The complexity of these integrations means that we tend to limit the partners we bring into the arrangement because each of them is additive on a cost basis, although fully worth it in the long run. One area I'd like to highlight that I think we need to think differently about is how we look at longitudinal length of stay and cost data as the shift away from hospitals continues. The overall acuity for inpatient stays will increase, which will drive up the average length of stay and the average cost per stay, which seems a little counterintuitive, but it makes sense if you think about the concept of the average. And we're already starting to see this trend in our own data. Some thought will need to be given to how we best assess hospital cost and efficiency in the future. Sticking on the financial side just for a moment, a couple of observations on the operating margins. All of the hospitals, including UC Davis, are facing significant capital investment related to compliance with seismic requirements. One element of securing necessary bond funding requires buildup of capital, which impacts the operating margin. Additionally, there are some differences between the accounting standards we are subject to and how OSHPD asks for data to be reported. So our operating margin, as reflected in our audited financials for 2018, was 7.9%, and actually dropped to negative 1% in 2019. So it's a very fluid measurement. On the behavioral health side, we agree with many of the observations about behavioral health. UC Davis Health has a long history of partnering with the county to provide behavioral health services at the county treatment center, in the jail, and other services to support this very vulnerable population. We're committed to working with partners to link these sites and our emergency department with more robust wraparound case management to help prevent and divert patients with mental health disorders from needing to use the highest tier of services, the ED, inpatient setting, and directing them instead to the right services at the right time in a hub and spoke model. The transitions between the health plan and county funded services are pretty bumpy. We would support the development of a transparent and consistent patient assessment strategy to know which level of care a person needs and better coordination into and out of the county funded services, regardless of which health plan is involved. And then finally, on the health information exchange, we're fully and enthusiastically supportive of exchanging health information with those who have a need for the data. We want the right data to be available at the right time for any provider that needs access to information we have. And we're constantly expanding information exchange through multiple national networks. We're currently in the process of planning an external API gateway to support compliance with 21st century cures requirements. And we think that will allow us to use it for other use cases. I will note we have drawn a box around this, which has probably impacted the RIOs and other health exchange information organizations, where because we make our data available directly, we don't pay to participate in RIOs. We're also fully supportive of the efforts to address the exchange of data for behavioral health patients. And for the policy folks who are attending today, it seems that the focus on HIE has been potentially a bit myopic toward the inpatient setting. And I'd suggest a need to focus very quickly how to advance the use of electronic health records in SNFs, other post-acute settings with community providers, with specialists. This is a major blind spot for emergency and high-end specialty services and really needs attention, particularly as we move to more services provided in the home and alternative settings. Finally, the HIEs really are that integration with the external outside of the inpatient setting is really necessary as we think about the sweeping positive change that CalAIM promises, but we really need to address this. Thank you for the opportunity to participate today, and I look forward to the rest of the discussion.
Thank you so much, Anne. That was just perfect. And there are already several questions about data exchange. So I'll certainly appreciate the remarks and we'll certainly loop back to you on that. But for now, let's move from the hospitals to the health centers. It's my great pleasure to introduce Britta Guerrero next. Britta is the CEO of the Sacramento Native American Health Center, an FQ located in Midtown. Britta, can you unmute yourself, turn your camera on, and let us know how do things look from your perspective?
Absolutely. Thank you so much, Christoph, for having me. This has been such a thorough review of the Sacramento area, and I'm really excited to be able to participate. I think what was most impactful to me was the FQHC growth. Seeing that we manage the majority of Medi-Cal lives, and we have quite complex care delivery systems that we're serving predominantly people of color, and we're the trusted members in our communities, and the important roles that FQHCs play as part of the safety net health delivery system. If there were some opportunities for improvement, I think there's definite opportunity through partnerships between the FQHCs, the hospitals, and the managed care organizations to serve our communities and to serve our patients where they live and where they work. What was kind of unknown to me as we move forward, what will the role of FQHCs be as the Medi-Cal population continues to grow as a result of COVID and unemployment and the changing economy? And what have we learned from FQHC's successes in our abilities to vaccinate and test, to do COVID testing on hard to reach populations? And if I was to pose a policy question, I think we've seen the impact of telehealth on Medi-Cal populations and hard to reach communities during the response to the pandemic. And I'm interested to see in how that will play out going forward. It's hard to provide a service and offer additional access and then see that go backwards. So I'm really interested to see how that will play out on a policy level. Thank you so much.
Thank you, Britta. Look forward to hearing a little more of your thoughts on some of those areas, and would note you've already got several kudos on your green screen. So thank you also for bringing that with you this afternoon. Next up, let's keep moving here. Let's move to more of a consumer perspective. We have Liza Thantrenon. Liza is Regional Counsel at Legal Services of Northern California. Liza, I see you have your camera on and your microphone unmuted. Please take things away.
Great, thank you. Hi, everyone. I'm Liza Thantrenon. As Christoph said, I'm an attorney with Legal Services of Northern California. If you're not familiar with us, we provide free direct legal services to health consumers in 32 counties. One point I wanted to touch on from the report is that geographic managed care model is crowded and chaotic. Because of the number of counties we cover, we work in a variety of Medi-Cal managed care models. 14 of the counties we cover are COES counties, 16 are regional model counties, and then we also cover 1 two-plan county, and of course, Sacramento. So I can definitely attest to the consumer confusion and navigation issues that result from GMC being crowded and chaotic. We have a lot of health plans, and on top of that, a lot of medical groups. And having a plan join and leave the network, having contracts fall through between plans and providers causes a lot of disruption. There's definitely a lot of confusion, especially as people change from employer plans to Medi-Cal, or they're changing from Medi-Cal plan to Medi-Cal plan. I've definitely had a lot of clients say to me of, like this provider told me that they accepted HealthNet, for example. And so I changed my plan from Anthem Blue Cross to HealthNet, and now I'm being told that I can't actually see that provider because I'm not in the right, medical group. And so it's not just being in the right plan, you have to also be in the right plan and provider group, and it just causes so much confusion with consumers. We were part of the conversation around what kind of model is Sacramento going to move to. There was a lot of discussion around GMC's maybe too many plans, is maybe COES a better model? And we definitely voice that in our COES counties, consumers have fewer consumer protections because they're not DMHC regulated, they're not regulated by the Knox-Keene Act. So we did not advocate for switching to a COES model. Having, I think, that IMR process in the managed care model is really important for consumers. We help consumers do appeals. So anytime folks get a denial from a health plan for a service, we help people through the appeals process in a GMC model or any other model that has DMHC regulation. We can take those appeals to an independent medical review, whereas in a COES county, we can only avail ourselves of a state fair hearing. And it's a really big difference in consumer protections when you are presenting, what should be a clinical decision about medical necessity to an administrative law judge versus an independent medical reviewer. So I would definitely advocate for staying away from COES for Sacramento, but maybe with a model that includes fewer plans to clear up some of that consumer confusion. Another point I wanted to touch on is the behavioral health provider shortage. I think that among consumers, there's definitely a sense that mental health services is really difficult to access for Medi-Cal folks here in Sacramento. And whether that's true or not, for example, I work really closely with the Gender Health Center, and they are a really awesome organization. They provide free or low-cost mental health services, but they operate on pretty much a volunteer model. All of their counselors are volunteers or interns. And so with that group, I see a big population of folks who are have this sense of mental health services being difficult to access through their Medi-Cal plan or through the county. And so they feel like they have to go to the Gender Health Center instead, which is super impacted. They have a super long wait list for services. And, they think there's already a shortage of behavioral health providers. Like, we have this sense from the community that it's difficult to get mental health services. And, this is a group that needs kind of like a niche. If there's already a behavioral health provider shortage, how are we going to find behavioral health providers who are culturally competent and know how to serve transgender and gender nonconforming folks? So, within that provider shortage, this community is even more impacted. And I think that's why we see these organizations like the Gender Health Center being so impacted for free services. And so that's all I have to say, but I'm looking forward to other questions and other discussion with the panel. Thank you.
Liza, you touched on a lot of really interesting issues there that I hope we're going to get to discuss a little bit more in the Q&A. But first, let's finish with our panelists here. We're very privileged to have Ryan Quist, Behavioral Health Director for Sacramento County, with us. Ryan, I see you have your camera on and your microphone is unmuted. How do things look in Sacramento from your perspective?
Well, good afternoon. Thanks. And I want to start off by appreciating the focus in this report, including behavioral health. I think we've all come to understand the importance of behavioral health as a nexus among a number of other aspects of both our society as well as healthcare in general. Want to start off and talk about, just can't ignore the context of COVID-19. Within the context of COVID, overall, we've seen reduction. The Department of Healthcare Services reports that during the pandemic, the demand for all Medi-Cal services, so in general, Medi-Cal services has actually gone down, including hospitalization and ED visits. And the only type of Medi-Cal services which has seen increased demand during the pandemic were behavioral health services. So we know that this situation is impacting behavioral health. We know that we have a lot of demand out there. County's response to COVID has been to quickly transition as many services to phone and telehealth-based platforms. But we still continue to do a number of essential services that require an in-person presence. We still continue to provide those services. Despite rising to meet the need during COVID-19, unlike with physical healthcare systems, we were provided no dedicated federal or state relief to shore up our system. And as a result, our workforce, providers, and systems have been stretched. Talk a little bit about our workforce issues. We are seeing a number of individuals opt out of our workforce because either they themselves are at risk for COVID or maybe somebody in their household is at risk for COVID. And a lot of times they are opting to try to find jobs where they are able to telework. And so this is adding to our challenges, especially within contexts with staffing ratios like our inpatient facilities. We're also seeing an increase in the length of stay in our inpatient psychiatric hospitals because finding appropriate post-discharge placements for individuals has become difficult because all of the typical placement alternatives are having to practice safety precautions and social distancing, reducing their capacity. This has led to backing up throughout our entire system in terms of being able to admit more people into the psychiatric hospitals, as well as back up into our EDs at times. It's sort of been a wax and wane in terms of how it is at any one point in time. So COVID has been a very challenging situation. I would like to talk a little bit briefly on the IMD exclusion, which is particularly relevant here in the Sacramento region. In Sacramento County itself, we have 3 large freestanding hospitals with more than 16 beds. And this is the main source, this is the main way that we support our inpatient consumers. Without Medi-Cal reimbursement, the federal funding, our inpatient budget is going out twice as fast as it should be as if we were able to claim to Medi-Cal. So the proposed IMD exclusion waiver that the governor's administration is discussing and that we're hearing about from Department of Healthcare Services is going to be very important and very impactful here in Sacramento County. We want to express our support of CalAIM. CalAIM, thank you to DHCS for including such a prevalent focus on behavioral health as a part of the initiatives that have been discussed and presented and proposed. We're very excited about those proposals. The first one, documentation modernization. Our workforce spends about up to 40% of their time doing paperwork. And that's 40% of their time that they aren't providing care. And our documentation requirements are not on the same level as you see elsewhere in the healthcare system. So if you do a comparison between what's required for documentation for physical healthcare, you'll see that behavioral health has much more strenuous documentation requirements with much more fiscal risk if those documentation requirements are not met. The second component of CalAIM that we're excited about is payment reform. We're currently in a certified public expenditure CPE method, which constrains us to exactly our cost. So we're always reimbursed at only our cost, which requires significant reporting requirements, leaves our providers, the folks that we contract with to deliver the services, leaves them with carrying financial risk for 1 to 2 years after a fiscal year ends, where they may owe us money or where we may owe them money. And it leaves the county with about 7 to 8 years worth of risk, where the state owes us money or we owe the state money. In Sacramento County, we estimate that the difference is that the state owes us about $8 to $9 million a year. And the last settlement was for fiscal year 13-14. So that's a number of years worth of reimbursements that we're still waiting on. And I'll stop there. Thank you very much.
Ryan, that was terrific. Thank you for that perspective. At this point, we do have about 15 or 20 minutes for general Q&A with the panel. So I would invite all of our panelists to turn their camera on and unmute themselves. And as a reminder to our audience, please feel free to ask any questions that you have for the panel. Put those questions into the Q&A box on your screen, and we'll do our best to get to it. But let's get started. Lisa, can you get us started with our first question?
Sure. We have a question from the audience. Can you talk more about regional health information sharing? In particular, could a one-time infusion of funds help with this? And if so, who's going to coordinate that?
What a good question. I think each of our panelists has touched on data sharing at least a little bit. And so I'll put you all on the spot, actually. Anne, do you want to kick us off? Do you have any perspective on that?
Yeah, I mean, I think that first of all, the national interoperability standards will help. But in the end, this is a very technical endeavor, and it unfortunately isn't a one-time thing. So we can do one time to implement an EMR, for example, but there will be ongoing costs around that and continual efforts around ensuring that the data exchange itself is working. So it does require ongoing commitment to that. And in terms of who might manage something like that, if there were a significant infusion of cash suddenly available, my inclination would be to say that's something that a foundation, you might want to look toward them to at least manage the financial side of that in terms of selecting where the money would go.
Thank you. And Britta, I know you had just briefly touched on some of the data exchange challenges and work that you're seeing at an FQ. Do you have any thoughts on that?
Well, I think we're operating in multiple interfaces. We have a different interface for each hospital system in which we work. And we also are working with interfaces in managed care plans. And so actually bridging that communication between the managed care plans and the hospitals would open up opportunities for the FQs. Currently in Sacramento, we are all participating in a new product that's called Unite Us, and that's really focused on the social determinants of health, but provides a BAA for all of us to share information on referrals and connection by community benefit organizations for providers. And there is a component that could work, and I think they're still testing that. For many of us, we have interfaces within our EHR, but I don't think there's any one EHR that has access to all of the hospital systems. So it's, 3 are very user-friendly and 1 remains kind of hit and miss. And, it's evolving. It's an evolving process. I would love to see one of our consortia. We have a community clinic consortias work with some of our hospital partners to do some testing to see what might be the best opportunity for all of us.
Thank you very much, Britta. Liza, I don't know if it comes up with the consumers at all. Do you hear comments and insight from consumers when it comes to frustrations around data exchange? Or on the other side, are you seeing our consumers seeing progress on this front?
Not really. I think the biggest issue that we see is sharing of medical records when we have some clients that change providers really frequently, and then sharing of medical records becomes an issue. But other than that, not really. It's not something that folks bring up to us.
Great. I think I heard that you're a little quiet, so we'll ask you to speak up next time, but definitely appreciate the perspective. You know, there was one other question that came in specifically related to data exchange that I want to try to get in here, and I'll direct this to you, Ryan. But can you talk a little bit about some of the ways or some of the efforts that are underway to improve data sharing, particularly on the behavioral health side?
Thanks. The place I'll start is some of the challenges that we continue to have are around both expectations of consumers around when they're sharing information with their provider, whether or not that information is going to be shared elsewhere. And I think to a large extent, our consumers have an expectation that it won't be shared, that this is a private conversation. So that sort of makes it difficult. Of course, that requires us to do things like do release of information, mechanisms and workflows. The option that we're looking at is something called Care Quality, which is a tool that the EHRs use in order to talk to one another. And we're having good success in that direction. I think it's sort of a mix between wanting to be able to make sure that the right folks have the right information, as well as managing our consumers' expectations.
Really appreciate that perspective. We do have a number of questions, so I do want to move us on a bit here. Lisa, can you help us with the next question?
Yes, the next question relates to telehealth. Are you seeing a trend to use telehealth services for behavioral health, especially given the pandemic? And are hospitals embracing embracing telehealth as an alternative for care?
Yeah, Anne, your name starts with an A, so you're going to have to go first on this one. Do you have any thoughts?
No problem. Happy to go first. We at UC Davis Health, we have a long history of embracing telehealth, both locally and across the far reaches of Northern California. The pandemic has been, frankly, a welcome catalyst for us in really bringing telehealth into people's normal routines. We do use it very frequently now with respect specifically to the behavioral health issues, because people can access it wherever they are and they don't need to come in. Our specialists are trained and use it on a regular basis.
Yeah, and Britta, I know telehealth has been huge, and you touched on it a bit in your remarks, but can you talk about some of the ways in which you're using telehealth for behavioral health services at this point?
Absolutely. We saw on average at FQHCs, we have between a 20 and 30% no-show rate, and that is the highest in the behavioral health department. We actually saw during the transition a very steep climb in the show rate because it was the removal of barriers, so childcare, transportation. If folks are having anxiety, over 50% of our patients have co-occurring disorders and chronic conditions. So co-occurring disorders meaning a behavioral health issue in conjunction with a chronic condition. So there was a lot of anxiety around leaving the house to actually come into appointments. Within the first 4 weeks, we went from a 26-ish percent no-show rate to 106% show rate, meaning that we had folks waiting on standby for someone to not show, which I think really is evidenced by the need for behavioral health, anxiety, depression, isolation. All of these things were magnified during the pandemic. And I don't think we've even begun to understand the trauma that we've experienced as a community and how long we're going to need to have these services available. When we talk about Medi-Cal populations and hard to reach populations, we weren't using telehealth as a substitute to visits, but in addition to visits. So our patients were able to be seen regularly and then come in for one appointment. I just think there's a lot more flexibility that needs to be available for our hard to reach populations and folks who have so many barriers in accessing care.
Definitely hear that and appreciate that perspective. Liza, in your remarks, you did mention access to mental health care as being a pain point for consumers, and certainly the difficulties around recruiting and retaining behavioral health clinicians. Do you have early perspective on the use of telehealth for behavioral health services from the consumer perspective? Is that working right now, or is it a work in progress?
Yeah, I mean, all the feedback I've gotten from consumers about telehealth services has been overwhelmingly positive. There, a few people who are like, I don't want telehealth, I want to go in person, but on the whole, people have been really excited about the availability of telehealth, and I think it's a really great tool to expand access.
And Ryan, are you finally, on this question, are you seeing any, particular trends around the use of telehealth to provide behavioral health services? Are there certain types of visits or services that are more or less conducive to telehealth?
First, at the beginning of the pandemic, we very quickly converted pretty much everything to telehealth except those services that are required to be in person. As time went on, we heard from some consumers that they preferred to be in person. And I remember early on in the pandemic, I heard a story about an LGBT youth who was living at home and going into their closet to try to have a conversation with their provider. So basically what I took from this is that I think that telehealth is going to be something that stays with us beyond the pandemic, but we're going to have to be very thoughtful about when it's clinically appropriate to do things in person.
Certainly appreciate that perspective. Would like to move through, keep moving through these questions. We have a number, and I would continue to encourage our audience members to input your questions into the Q&A box. Lisa, can you give us the next question?
Yes, we have a question. What is meant by, or what does Len mean by control when the report says that 70% of PCPs, primary care providers, and 80% of specialists work for a medical group controlled by a hospital or health system? Does this include Kaiser and the University of California? And if so, how much of this is Kaiser and the UC system?
Would love to get your perspective on that, Len, on the methodology and kind of the technical question. And then I would also, if you're willing, in, you had made some remarks at the outset about consolidation and potentially rethinking some of those measures. Would love to hear those thoughts too. But Len, why don't you get us kicked off?
Sure, thanks. So those numbers come from a study that was done by UC Berkeley last year, looking at how physicians have affiliated with hospitals and health systems. So control, by that we mean either they are employees of a foundation of the health system, or their practice or their IPA or their medical group is affiliated with the health system or hospital. And sometimes those affiliations can be exclusive, whereby they don't serve any other hospitals or health systems. So I actually don't know off the top of my head if Kaiser is included in that. I assume Kaiser is included in that study. And I think UC Davis is also included in that study.
Speaking of UC Davis, and you had made some remarks at the top about consolidation in the market. Do you have perspective on this?
Yeah, I mean, I think, as I noted, we are, as we within the system look to how can we improve integration of care and make sure that these handoffs are as smooth as possible so the patient is getting the right care at the right time. We've talked about it sort of around this subject, right? Some of it involves health information exchange. How are we getting the right information to the next person that we're passing the patient, that the patient is moving to? So there's cost associated with that. But really, the other area that the integration I find is extremely helpful is ensuring that our work processes are smooth and that the actual workflow that we follow provides the right information so that we're driving toward quality outcomes. And so I mentioned about the county mental health, across the board, Medi-Cal with a split between the mild to moderate, and the severe at the county, and each plan handles that differently. So that level, there's the disconnects across the board. But we find in integration in particular, the ability to know that the other people on the other end, the people we are partnering with, have the same workflows, are getting the same information, really improves the overall quality of care that patients are getting. But it does require management meetings, governance structures, financial transparency across the organizations in ways that are difficult if you're not fairly tightly aligned to the parties that you're working with.
Certainly appreciate the complexities and the nuance there. Lots to talk about there, and we do have a number of questions that I still want to just try to squeeze in here at the end. Lisa, can you feed us one or two more?
Sure. We have someone asking if a county organized health system is not possible in Sacramento, would a two-plan model be a plausible next best solution? I'll also mention that someone in chat has shared someone not with CHCF has shared some CHCF resources along this issue in chat. But is a two-plan model a plausible solution in Sacramento?
Complicated question. Britt, I'd maybe kick this to you and then ask Liza if she has perspective. But given the evaluation and the rethinking that's going on that Len mentioned around the GMC model, what do you see as appropriate next steps and preferable from the FQ perspective?
Well, I think we don't want to throw the baby out with the bathwater. I think we have, for FQHCs specifically, we have figured out ways to maneuver within the managed care system. And the health authority was actually developed in Sacramento County to build in some accountability. I think we have seen some difficulties with managed care plans entering an already saturated market and not bringing with them additional providers into their network. Actually, the CHCF benchmark that we use is the 25% of Medi-Cal referrals were actually completed within a managed care environment, and we are hovering right there about 25%. And I think there's a lot of opportunities for improvement there, obviously, and there's some solutions that I think we could consider with the county and having the county offer some additional specialties. The FQHCs have really worked to solve many of our own problems in that we've brought specialty providers in-house. And in using that same data that CHCF presented on successful referral life cycle, we're completing internally about 55% of our referrals to specialists that we've brought in-house. So podiatry, chiropractic care, psychiatry, optometry, endocrinology, and we partner with other FQHCs to make sure that they also have access. So I think there's a lot of opportunity for improvement, and as the health authorities structure evolves, I think we're going to be able to identify some of those pain points and really work on those as a collective. I know that procurement is happening this year and that the state of California is looking to decrease the number of plans that it contracts with. And I think we can really look in a solution-focused way at things that we can do to improve outcomes by working better together and really identifying those pain points and coming up with some really strong work plans on how to incrementally make those changes. I think a big jump immediately would be a little bit scary, and it would really upend patients like we saw when United left. And that really did cause a lot of havoc. And we saw a lot of folks leave the Sutter network. And it did cause a lot of strife for patients. And I think whatever we do has to have the least impact on patients. And I think we forget about that when we're looking at things from a systematic perspective. So I would just caution us from moving too quickly.
Certainly appreciate the perspective. And unfortunately, we're out of time. So Liza, I'll have to ask you to hold your thoughts. And Anne, I know you're involved in a stakeholder process with Britta on that, as many folks attending this call are. Two quick things before we wrap. For the audience, first, the slides, a recording of this webinar, the report, they're all available on our website at chcf.org in the coming days. Second, you're about to get an evaluation screen that's going to pop up. Please do take 30 seconds and I'll fill that out. We will definitely look through it. So with that, thank you to our panelists. Thank you, Karen, Angie, Scott, everyone behind the scenes, and thanks to everyone in the audience for joining us. I really appreciate it, guys. Thank you.